Hi class, this is Dr. Heather Austin Robillard, and this lecture is going to be over special populations, specifically in regards to children, adolescent, and eating disorders among those populations. While the median age of onset for eating disorders is between the ages of 18 and 21, we do know that research is showing that eating disorders are developing in younger and younger children. We do know that 2.7% of adolescents between the ages of 13 and 18 are struggling with an eating disorder today. Females make up about 90% of those. However, we do know that boys are struggling with it as well. It has been found that 10% of the hospitalizations for eating disorders were those of children who were under the age of 12. So it's definitely become a problem for children and adolescents. However, we're probably going to need to treat it and diagnose it differently. In this lecture, we're going to identify some of the unique components that make up of eating disorders among children and adolescents. So in this lecture video, when we're talking about children, we're talking about children defined in the ages between 6 and 13. Only a small minority of children will meet diagnostic criteria for eating disorders as they are discussed in the DSM-5. Children with eating disorders are less likely than adolescents to engage in binge eating and purging, and they primarily meet more similarities to anorexia nervosa. Restriction is the most common behavioral characteristic that we see in children. Children are less likely to be diagnosed with bulimia nervosa, and the biological and course of illness factors unique to children translates to higher physical and medical risks. Diagnosing eating disorders is difficult as many children have atypical presentations. We also know that diagnostic criteria is primarily applied to older patients and may not adequately address the problem of eating disorders in children. Think of prepubescent and them not actually struggling with a missing period. What we do use instead is the Great Ormond Street criteria. This tends to address the issues of the diagnostic criteria not meeting the criteria met for children with eating disorders. Let's take a look at the Great Ormond Street criteria. For anorexia nervosa, it's got 3 criteria. There's determined weight loss, so they've had food avoidance, self-induced vomiting, excessive exercising, or even an abuse of laxatives. They have abnormal cognitions regarding their weight and their shape, and they tend to have a morbid preoccupation with their weight and their shape. For children with criteria for bulimia nervosa, we would look for reoccurrent binges and purges, a sense of lack of control around food, morbid preoccupation with their weight and shape. So while we can see there's some similarities to the criteria located in the DSM-5, they may not meet other specific criteria, so it would be better to focus on the Great Ormond Street criteria. Specifically, anorexia nervosa weight loss in young children may take in consideration static weight. Food avoidance may be reported as being a fear of becoming obese or feeling nauseous or full, even struggling with abdominal pain or difficulty of swallowing their food. Laxative abuse is not common in children as it is in adults. However, abnormal cognitions are difficult to assess in children because of their ability to communicate. In the DSM-5, there is a feeding and eating disorders category, which is characterized by persistent disturbance of eating or eating-related behaviors. This results in altered consumption or absorption of food. It can cause significant impairment in an individual. Anorexia, bulimia, binge eating, and other specified feeding or eating disorders are eating disorders, whereas the not yet discussed are Pica, rumination disorder, avoidant restrictive food intake disorder, or unspecified feeding and eating disorders. The rest of this lecture, we're going to talk about some of those not yet discussed categories. First, let's take a look at Pica. Pica is defined as a regular eating of non-food and non-nutritive substances. Many clinicians work with children with Pica report that the child eats hair, glue, dirt, and various of other substances. It is categorized as a feeding and eating disorders chapter in the DSM-5. In the chapter about Pica, they also talk about how it is considered developmentally inappropriate eating, whereas like some small children might put things in their mouth. This is specifically at a developmental stage that is inappropriate for them to continue to be eating non-food substances. Some other items that are often ingested are those of paper, chalk, glass, even feces. Some of the consequences with this can include poisoning, abdominal perforations, blockages. Pica is most commonly encountered by clinicians when working with children with intellectual disabilities. It can also be found in children with sensory needs, including those who seek an oral stimulation, and most typically with those who are on the autism spectrum. However, pica can also occur in normally developing children, but it tends to be overlooked more so in those instances. There are very few studies that have examined the prevalence of pica in young children. However, there was one study in Germany that had about 800 children found that pica behavior was reported to have occurred at least once in 12% of the children who were ages 7 to 14, and the reoccurrence of this behavior was reported in 5% of those children. In the DSM-5, pica has multiple criteria in order to meet this diagnosis. The first one is that it has to be persistent eating of non-nutritive, non-food substances for a period of at least 1 month. The eating of this non-nutritive and non-food substances is inappropriate to the developmental level of the individual, and the eating behavior is not part of the culturally supported or socially normative practice. If occurring with another mental health disorder or during a medical condition, it is severe enough to warrant independent clinical attention. Another disorder that is more commonly found in children is rumination. This is the process of bringing back up or re-chewing partially digested food that has already been swallowed. Individuals do not present as being upset, retching, or disgusted with regurgitation. It can go away without treatment, however, some cases require professional attention. It occurs in infants, but is rare in children. The medical risks that occur in rumination are they need to be checked for anemia. This may lead to a failure to thrive. They could have a lower resistance to disease and even some malnutrition. So the DSM-5 criteria for rumination includes repeated regurgitation of food over a period of at least 1 month. Regurgitated food may be re-chewed, re-swallowed, or spit out. The repeated regurgitation is not attributable to an associated gastrointestinal or other medical condition. And the eating disturbance does not occur exclusively during the course of anorexia, bulimia, or binge eating disorder, or avoidant restrictive food intake disorder, which we'll talk about next. If the behavior occurs within the context of another mental health disorder, maybe a generalized anxiety disorder, or a neurodevelopment disorder like an intellectual disability, it must be sufficiently severe to warrant independent clinical attention. This next disorder is called avoidant restrictive food intake disorder, or AFRID. This is a new diagnosis within the DSM-5. Individuals who struggle with an impaired or distressed eating behaviors and symptoms. The consequences of restrictive avoidant eating results in significant weight loss, growth compliance, reliance on nutritional supplements to meet their daily energy requirements, nutritional deficiency, a marked interference with their psychosocial functioning. In order to be considered AFRID, they must lack weight and body image concerns that are associated with anorexia or bulimia nervosa. So the AFRID fears about eating may concern being fearful or stressed, reacting to stress or trauma, reacting to the messages about food like dangerous foods or chemicals, restricting to avoid pain, nausea, or a risk of choking or vomiting, and restricting to avoid adverse tastes or textures, or reacting to stressful emotions around mealtime. So AFRID is also sometimes considered a picky eater. The announcement of AFRID met with criticism about pathologizing picky eating. AFRID used identifying those with restrictive eating creates clinically significant problems. Picky eating, or children who have normal weight but consume inadequate variety of foods through the rejection of foods that may either be familiar or unfamiliar to them. Picky eating limits the variety of food they eat, unwilling to try new foods, or may reject foods based on smell, color, or consistency or texture, which is not the same as aphrid. So in this lecture video, we discuss the unique parts of eating disorders in children and adolescents. This includes the diagnosis like Pica, rumination, and avoidant restrictive food intake disorder. It's important to understand the differences of these disorders from the full threshold eating disorders that are more likely to be seen in adults. Thank you.